Hello, thank you for joining Manatee County EMS in our training and preparation for infectious diseases that you could confront in the field. Today we're going to do a short overview of the Ebola virus, descriptions and statistics, before we then go over our infectious disease procedures. So to start off, we're going to talk about Ebola and where it's at today. Current U.S. statistics, as of November 19th of last year, 2014, there were 6 Ebola virus disease patients that had been evacuated from West Africa for further medical care to the United States. As a result of that, there were 2 secondary cases of the Ebola virus diagnosed here in the United States of people who cared for them or were by them. Clinical presentation and clinical course so that you're familiar with the disease and can recognize it and what its signs and symptoms are. It usually has an abrupt onset of fever and symptoms, typically 8 to 12 days after exposure. The incubation period for the current outbreak has a mean of approximately 9 to 11 days. That varies. Symptoms may appear anywhere from 2 days to 21 days after the exposure. Initial signs and symptoms are nonspecific and may include elevated body temperature or subjective fever, chills, malaise, etc. We'll talk more about signs and symptoms as well as when it's most infectious. The most common signs and symptoms are listed on this slide. Reported from West Africa during the current outbreak, from symptom onset to the time the case was detected, were most common fever, fatigue, vomiting, diarrhea, and loss of appetite. Bleeding is much less common, and universally, it is not universally present. Many patients do not have it, but it can manifest later in the course as petechiae, ecchymosis, or bruising, or even oozing from venipuncture sites or mucosal hemorrhage like you see in the picture on the screen. Unexplained bleeding has only been reported from about 18% of patients. Most often it's blood in the stool with about 6% of patients. Fatality rates. In West Africa, it's about 71%. Nigeria, about 46% of the people who catch it get the virus die from it. Guinea, Liberia, and Sierra Leone are 69 to 72%. And you see the charts listed below through the various years. The other thing you notice on the chart listed on the screen is that you see they've been tracking this disease on and off since 1976. Although we're only hearing about it now here in the United States, this is not new. Some fatality factors. Patients with fatal disease usually develop more severe clinical signs early during the infection and die typically between day 6 and 16 of complications, including, but not limited to, multi-organ failure or septic shock. Risk factors associated with fatality include those greater than 45 years old, those that get unexplained bleeding in association with the virus, and a number of other signs and symptoms as listed below tend to go along with those who become fatal. Non-fatal cases. Patients may have fever for several days and improve typically around day 6. Patients that survive can have a prolonged period of trying to get back to full function and energy. Treatment. Unfortunately, there's no complete FDA-approved vaccine or medicine for the treatment of Ebola. It really is predominantly supporting their symptoms and getting them through it. Symptoms of Ebola and complications are treated as they appear. Basic interventions, predominantly intravenous fluid, and balancing their electrolytes, maintaining oxygen and blood pressure, and treating other infections that may occur while they're ill. There are some experimental vaccines being used, but none of them have been tested well enough to fully say whether they're effective or not. Recovery. Recovery from Ebola depends on good supportive clinical care as well as the patient's immune response. The interesting fact is that people who recover from Ebola infection develop antibodies that last for at least 10 years. You may remember hearing from individuals where they have used the blood of an infected person in transfusion to new infections, and this is related to this antibody. Modes of transmission. Got some interesting pictures on this slide, and there's good reason for it. Modes of transmission are blood or body fluids, including but not limited to, and you notice that this list is much more broad than a more limited list for something like HIV. It is and can be spread by urine, saliva, sweat, feces, vomit, breast milk, and semen of a person who is sick with Ebola. This is why patient contact has to be limited if we do encounter an Ebola patient, because simply their sweat on their skin can transfer it to you, and is more than likely the way it was transmitted in the cases here in the United States. Objects like needles and syringes that have been used or contaminated with working with the virus, or a patient who was infected can also spread it. And the reason for the pictures, it can also be spread by infected fruit bats or primates like apes and monkeys. You notice in one of the pictures, yes, that is a grill that probably has rats and bats cooking on the grill. In some of the infected areas of Africa, they actually eat these and spread the disease in that way as well. You ready for lunch yet? All right, chain of transmission. What we want to do in caring for these patients is prevent one of these chains, because if any one of these chains is blocked, it can't transmit from one person to the other. You have to have a receiving host, somebody that is infected with the disease. Secondly, you have to have a portal of entry for the infection or virus to get from the original host into the new person. Again, unfortunately, the hard part about this is that their sweat getting into a mucosal membrane or possibly even through your skin could allow transmission. This is where this is much more viral than other things that we've dealt with in the past. You have to have the causative agent and a mode of transmission to get from that person to you. And this is where within what we'll talk about later, we put barriers to prevent that. Healthcare transmission. Healthcare workers that have been affected by it. As of October 23rd of 2014, there were 450 healthcare personnel known to have become infected with Ebola. Of those 450, 244 died. This slide is to give you a little bit of an idea of the life cycle and why it's most infectious and when it's most infectious. You've heard it said on the news, I'm sure, that until they get a fever, they're really not contagious. And it's due to this, this slide helps explain that as to when they're most infectious. And you see there around day 5 is when it's the strongest. That's really when it's most likely to transmit from person to person. And when it's the strongest is also when they get a fever. So this just kind of helps show the progression. And in those early stages, it really is not contagious because there's not enough of it in the system to be able to spread to the next person. Okay, so what does this bring us to today here in Manatee County? Well, we are very fortunate to have a lot of leaders within our county that have spent a lot of time in developing our infectious disease standard procedure. And we're going to go through some of the highlights of that today. This was last revised November 18th, 2014, and I want to really thank Jake Sauer, Paul DeSico, Chief Kravanek, representatives from the Manatee County Health Department, Dr. David Nonell, our medical director, and many others, and our Manatee County Hazmat team for working and giving input to the development of this. And I apologize if I left anybody out, but many, many hours were planned to prepare this. So with that being said, and Chris Gold, Mark Laraway, you see some other names listed there, Emergency Management, thank you for all of your help and input into this. So the plan includes, and for any of you who are Manatee County EMS employees getting this training, you know that this plan is available through the intranet. Anybody else in the county that's involved as first responders can get a copy of it from us. ECC may notify first responders of the suspected infectious case over the radio. The phrase possible PUI would be what would go across the radio. PUI standing for person under investigation. This would let you know that you need to initiate precautions before ever getting to the house, certainly before going into the house. You should be monitoring your computer for updates that may tell you whether the patient's nauseous, has vomiting, diarrhea, stomach pain, fever, or other related symptoms, as those questions will be asked by the 911 call taker. This should reinforce the first responder's decision to ask key screening questions before anybody makes contact with patients or enters the house if possible.
With that section, they're not actively screening now. There's only actively screening going on if patients on the phone tell them that they've been to West Africa or they may be an Ebola patient. Currently, that protocol is not being used.
But it is being used currently if
they say those words like West Africa. But it's not every flu-like symptom are they being asked those questions. That makes sense. So not every flu-like symptom gets asked, have you been to West Africa? You know, have you been traveling? What type of fever? Blah blah blah. That's not in those questions right now. Currently, it's that. You know.
All right, I'll back up.
Maybe they need to clarify it. You know, not to say it won't happen in the future, but right now, this is what we're doing.
Just to make sure that all first responders are aware, some of the 911 call takers' development to response of infectious disease, it may occur in stages, so there's never a guarantee that this information will be picked up through the call taker's questioning. And it, depending on what signs and symptoms they share in the beginning of the conversation, may or may not lead to the questioning of discovering whether they have these symptoms or even if they have traveled to other countries. So just understand that this is not 100% and it may be limited by the information that the caller provides. So what happens if you have been given the information that you're responding to a PUI? If indicated by the 911 call taker, they will, the 911 call taker will direct the patient to first meet us outside if they are able to ambulate. If the patient is not able to ambulate to get outside of the residence or location that they are at, there may be an entry crew required to don appropriate complete isolation before even entering to talk to the patient. And we'll talk more about that. Number of personnel interacting or questioning the patient should be limited to one, if at all possible, as few as necessary to prevent potential contamination. So if they have come outside and you greet them, you would want to stay outside of touching distance. If this is not an airborne disease, it's just very, very easily spread by patient contact, as we mentioned, with sweat and other bodily fluids. So you would want to begin further questioning them without touching them or touching any of their belongings. You might want to ask them some of these questions. Have you traveled outside the United States, or have you been in contact with someone who has in the past 21 days? If no, proceed with further questioning. If yes, continue with further questioning. If no, you can probably go with routine EMS care. And really understand, too, this is sometimes specific to Ebola. You may be dealing with some other infectious disease that even if they haven't traveled outside the country, you may still feel the need to take precautions and contact a supervisor. So if they have traveled outside of to West Africa or been in contact with someone in the last 21 days, you proceed with questioning, and where have you been in direct contact with them? Try to find out specifics. Again, do not make direct contact and contact a supervisor. Some additional questions you could ask is, especially, have they had a fever, or do they have a fever? Along with headaches, muscle pain, vomiting, diarrhea, abdominal pain, hiccups, which seems to be very common with this illness, or unexplained hemorrhage, may just make you even more cautious. Decision process. Suspect infectious disease. First responders shall notify the EMS supervisor of a suspected PUI patient on the designated TAC channel that you're working on. The patient does not meet the Ebola criteria. Don appropriate, if they do. If they don't, don appropriate PPE, your standard PPE, your goggles, your gloves, etc., and transport the patient. But you can make that decision after consultation with a supervisor. And know that that supervisor may be consulting with the epidemiologist at the Manatee County Health Department, giving the background, giving the findings, and getting direction from them as to how you should handle the case. We don't make these decisions alone. Once it's been determined that we have an potential infectious disease, whether it be Ebola or some other infectious disease, the following command structure will be set up and take place on scene. The incident commander will be a Manatee County EMS captain. With them, a unified command post may be set up, including fire, hazmat, and law enforcement. Department of Health will be notified, and again, we will take their input. Then a safety officer will be assigned. Will activate the Manatee County Hazmat team. They may have a representative come to the scene. They will also send a team to the hospital to set up for decontamination after the call. They will also probably assist along with the EMS supervisors and crew in preparing the ambulance for transport. Just to mention, we are constantly reviewing this plan for improvements. And since all of this has started, we have had one chance to trial this the plan, and as it stands right now, it may be changing, that the driver may not be put in a level C suit, but follow the directions of the EMS supervisors on scene, as the direction given to them comes from all the people that have input on this plan. After the crew has been donned in the suits, we will also try to incorporate the patient and prevent them from touching other things or passing to other parts of the ambulance or other areas the patient may go through. So after attending, EMS crew dons the PPE, the patient will be isolated in some kind of a fluid impermeable suit, a face mask with attached fluid shield, and gloves covering their hands if possible. Stretcher shall also be lined with a protective cocoon device or equivalent, again, when possible. Again, the idea is to contain their bodily fluids. Driver, while on scene, will be kept in a safe location away from the patient so as not to become contaminated, whether they are or aren't in a level C suit. No communication is required by the unit driver, especially if they are in a suit, as the incident commander will advise dispatch as they depart the scene, and someone else will be able to advise them when they arrive at the hospital. Must ensure that the ambulance remains secure with the doors locked at all times while the patient is in the ambulance, including at arrival at the hospital. This is to make sure that a family member or other staff member doesn't come up to the ambulance unknowingly and open the back and become contaminated until the driver is ready to open it for the crew, or the crew to open it from the inside. Treatment of the patient should be minimal at best. Non-invasive treatment may be performed by EMS or fire personnel, as an example, applying oxygen, but invasive procedures such as IVs or CPR will not be performed in a moving ambulance. Intubation, suctioning, or other aerosol-creating procedures will more than likely not occur, as directed by the Center for Disease Control and others. Again, it basically is supportive action. So you may ask, well, why are we going to have 2 crew members in the back of the ambulance? This is for no other reason, safety. The patient will be wrapped. The patient's going to be in an unusual environment. And if they should start to become upset or feel they need control, it's better to have 2 people back there. Once the ambulance arrives at the hospital, they will stage at the ambulance parking area, again keeping the truck locked until everybody is ready for the patient to come out. Once the hospital confirms they are ready and can isolate the patient, the crew will move the patient to the isolation area designated by the hospital. The EMS crew shall report directly back to their ambulance as soon as they have transferred the patient, again making sure they don't touch anything within the hospital that they don't need to. The driver shall relocate the ambulance to a decontamination area that will have previously been set up by the hazmat team and meet them for decontamination. The doffing and decontamination process will occur there under the direction of the hazmat personnel. It will be a slow, methodical process. Nothing in this procedure is meant to be done fast. It's meant to keep everyone safe. Employee wellness and surveillance. And just as a side note, during the one case that we've had so far using this procedure, it was literally about 4 hours in length. So again, nothing's going to happen quickly. After the call, crews will be monitored just as a precaution to make sure that nothing has been transmitted. Crew will meet with the Manatee County EMS designated infection control officer or his designee. As you know, at this time, that's Lieutenant Jake Sauer. Patient will be tested for the Ebola virus or other infectious diseases as suspected, depending on the case. If negative, the surveillance will be terminated, meaning if the patient has no infectious disease that we should worry about, there'll be no surveillance of the employees involved in the call. If they test positive, surveillance will begin and be monitored through the Department of Health. EMS employees that had direct patient contact with a confirmed EVD patient will receive medical evaluation and follow-up care. They will be monitored twice daily for 21 days after the last known exposure. They will be allowed to continue to work while receiving these fever checks, provided the PPE remained intact and that there was no known direct exposure to the patient, as all of this is done as precaution. Known exposure would be direct contact with blood, bodily fluids, secretions, or excretions from a patient with suspected or confirmed infectious disease. If that should occur, an example, a suit was to break and you were to touch the skin of the patient or something of that nature, or if you were to come in contact with a patient before you realize that they may be a patient of infectious disease, you should stop working, wash the affected skin surfaces with soap and water, including mucous membrane should be irrigated like your eyes as soon as absolutely possible, and contact the designated control officer. EMS personnel who develop sudden onset of fever, intense weakness, or muscle pains, vomiting, diarrhea, or other signs related to these diseases should not report to work and immediately stop working and isolate themselves. They notify their supervisor and notify the designated control officer for assessment and further follow-up and post-exposure services. Comply with work exclusions until they are deemed no longer infectious to others, and follow the instructions of the Department of Health. I hope some of this has given you a better idea of our exposure or infectious disease plan, and also has given you a better idea of where Ebola is at this time and what its real risks are at this current time here in Florida or in the United States. After this training, you will see 3 other videos or linked videos that go over the donning and doffing of these level C suits, as well as a panel discussion among the people who helped put together this plan. If you have any further questions, please ask during the practical portion of the donning and doffing, or contact one of your training department or your exposure control officer. Thank you very much for watching this training today.